Great. Okay. Thanks everyone for joining us for the March 15th Sustainable Cost Healthcare Cost with Target Advisory Committee. Hopefully folks are in the right place. As committee members join, it would be great if we could just turn on your cameras really quick. That helps the staff just get the quick count of who's here for the meeting minutes. While people do that, if you could take a look at the January 2023 minutes, if you haven't had time to take a look at the meeting summary. I have a quick announcement for those who joined the meeting that the closed captions are not the fabulous OHA staff. They are the automatic closed captions for Zoom. So please note that that's happening. If you need to turn on the closed caption, you can hit the little button at the bottom of your screen that says CC, and we have those available in English. Elena has put a link in the chat for the closed captions that are by the OHA staff that will be more accurate and less autocorrecty, I guess is the best term for that. Although I guess the auto captions just did autocorrecty, so they're not that terrible. Which I'm sure is not a real word. Are there, for me, it's really helpful. There are a lot of folks on my little boxes, but I actually can't see everybody and the slides. So I just want to remind people that down at the bottom of your screen is the little happy face with a plus sign above it and a little carrot pointing up. That if you have things that you'd like to say or jump in, it's helpful to hit the raise your hand gesture so that you pop to the top and I can actually see you and make sure that everybody's input is included. Finally, are there any changes to the January 18th meeting summary or any thoughts about that? Okay, great. Then we're going to hit these slides. As always, the fabulous Sarah Barterman's going to kick us off with what we're going to talk about today.
All right, let's go to the next slide, please. So just a quick agenda review. We have a couple of program updates that we want to share with you. We are going to share some data from 2018, 19, and 20. This is new data that we haven't talked about before.
Can I jump in?
Yep, I see Melissa.
Yeah, sorry, I was struggling on my laptop. I'm not used to using it for this. It's not noted on those January 18th minutes that I wasn't there. It also wasn't noted that I was there, but I was not there. I was not present. So just one change. Sorry about that. Sorry, Sarah.
Got it. Melissa, you were not at the January meeting, and that is not accurately captured. We will fix that. Thank you.
Wow. Melissa's such a good student. I just want to let that roll. Okay, Sarah, go ahead.
Okay, we're going to talk about some 18, 19, 20 data that we haven't shared before. So sort of hot off the press data to get some additional context and stage setting about what's happening in Oregon. We are going to continue our conversation about pharmacy strategies. You remember in January, we talked about a survey to decide how to guide the conversation and take it to the next step. So we have the survey results, and then we're going to have a little bit of a discussion there. And then new topic for today, we are going to do a little planning around our upcoming annual report and public hearing. So this is the first report and time period where we will be reporting payer and provider organization level performance. And we have some information to share with you about how we're planning to do that. And then we have a lot of questions for a discussion about what the public hearing looks like and how we do that in May. Public comment will be at 11:45, and that is everything I have.
Oh, Sarah, if we could move on to slide 3. As always, if just remember our group agreements, we have a heady step to move into today, especially with the upcoming reports on where we're at in the cost growth target. And I think it's really important to plan a good and robust public meeting so that we're hearing from communities and various stakeholders about this work that is happening. And so I want to encourage people think about that, and please jump in. I think, is there anything else on the group agreements? Great. All right, let's move on to program updates. Sarah, do you want to take it away?
Yep. Thank you. All right, so our first update is, you might have heard, Angela Dowling has left her position at Regents Cambia, and we are now recruiting for a new health plan payer representative to replace her on the advisory committee. So the recruitment announcement went out to the committee, the tag, our Gov delivery list, earlier this month, and we are accepting applications until March 17th. This new committee member will be appointed by the Oregon Health Policy Board, and we're hoping to do that at the April meeting. So new member hopefully joining us for our May meeting, and just a reminder that that recruitment is still open and that we're specifically looking for a health plan or payer representative. Any questions about the recruitment? Okay, next. The second update we wanted to share, back in January, we talked about creating a cost and equity work group. This would be a short-term group with a subset of committee members that would meet for about 6 months and further the discussion around cost and equity, and what does it mean to bring some of those equity considerations into our cost containment or cost mitigation discussion. So we had our first meeting at the end of February. In that first meeting, we talked about sort of the context and what our predecessor committee had talked about as it related to equity and quality and the cost growth target work. We also reviewed what the other cost growth target states are doing or thinking about in this space. And then we also reviewed a white paper that came out recently from Peterson Milbank program about incorporating equity into cost growth target efforts. So it was a pretty high level stage setting meeting, sort of a catch up on everything that we've already talked about and some of the other options, where other states are, what we might want to consider and how we shape that next conversation. So we'll be meeting again. The second meeting is later in March. These are public meetings, so folks are welcome to join. I know a number of committee members volunteered to be part of this work group, so thank you for that. But others are welcome to listen in as well and participate. So I think I want to stop and see if the work group members have anything that they would like to share or reflect back on to the full committee. Everyone's really quiet. Greg, I see you. Can I pick on you?
I don't have anything in particular to share at this time. No.
I'll jump in, Sarah.
Great, thanks, Karis.
Sure. The equity group, I just joined it because I really wanted to dive in a little bit deeper, and I think that we did get into some deep discussions just in that very first meeting and really have a clear focus. We talked about, what is our role and what do we want to bring back to this full committee, and I think we've got a clear mindset of what we need to do. But if there are ideas from other folks here, even if you don't want to serve on the committee, have some things that you want us to focus in on, please do pop them in the chat or get them to Sarah or Jonde and get that information to us, because the goal is to really dive a little bit deeper than what we do here in the area of equity. So please feel free to share. But excited to be a part of that group. I think we're going to do some good work.
Michael, anyone else? I don't want to cut anybody off.
I saw her dash come off mute.
No,
Yeah,
I think you summarized it, Karis, but I think you summarized it that we would need to get, factor equity into the cost and coming up with some kinds of initiatives, not necessarily for you to pick on, but something that you have to incorporate into your cost structure.
So we will continue conversations later this month, and those meetings are all posted on the advisory committee webpage as well. So you can see meeting materials and find the links for upcoming meetings of the work group there as well. And Michael, I understand Nathan is agreeing in the chat. Excited to figure this out together, he says. Thanks, Michael. Okay, next slide, please. So our last program update this morning is just where we are with the 2023 legislative session. So in January, we shared that 3 bills had been introduced in the House that would modify the cost growth target program in a variety of ways. And just an update today to let you know that on February 21st, the House Committee on Behavioral Health and Healthcare held a public hearing on 2 of those bills. So House Bill 2091 delays accountability mechanisms, and House Bill 2742 exempts certain costs from consideration as cost growth. So those hearings happened. OHA also provided an informational presentation to the House Committee on February 20th at their request. So since that public hearing on the bills in late February, nothing else has been scheduled. So just wanted to let you know the status of that, and I don't think we have any more information to share. Felisa, anything else from your perspective?
No, I don't think we have anything to add for the meeting.
Okay, then I think those are the updates. Any questions or comments?
Okay, let's dive into what we've all been waiting for. I feel like it's like that drum roll moment. So our first round of data has come out that includes portions of the pandemic, knowing and recognizing that this is an ongoing struggle in our communities. I don't want to set aside that we're still in these rise and falls when it comes to COVID-19 and other aggressive respiratory infections. So, I think that we've looked previously at the other cost growth data and the organ claims analysis. And this is the first time that we're looking at submissions that includes spending, but also non-claim spending and other dollars. So this also takes into account pharmacy rebates. And so we're going to actually be talking about pharmacy later today. And this is the first time we're looking at the impact of the pandemic, as I said. So I think this is highlights level, and I think this is an opportunity to ask clarifying questions. I want us to remember, that, Nick, I'll jump back to your question in just a sec in the chat, but I want us to remember that we've got to look at this data and that our role here as an advisory committee is we need to think about how we come up with strategies to help people engage and meet the targets. And how do we really think about moving that forward? We've pushed out the accountability already, if people remember in the PIPs, to make this decision. And so I think questions, thoughts, ideas, and my expectation, and I don't think Sarah's expectation, is we look at this and come up with the answers and we're like, aha. By the way, if you do have that moment though, please share. Don't keep it to yourself. So, but I think we're going to have these ongoing conversations, and I think we'll continue to talk about the strategies that we want to implement and the strategies we have implemented as they're working. So let's jump back to Nick's question. Sarah, do you want to take this?
Yeah, Nick asks in the chat if the advisory committee has any role in commenting on the draft bills. And that's a little bit of a tricky question for me to answer as staff. So OHA does not have positions on bills, and we cannot
answer that.
you to do that. But I want to say, as members of the public and as a committee, you could certainly make some decisions about that yourself.
Sorry, Sarah, didn't mean to. Let me kick it. So the general rules is the governor sets the agenda for state agencies. And so unless you are an independent board that is appointed by the governor in a way and have specific authority in legislation, actually we sort of can't comment as a committee on something unless the governor agrees that that's the case. So the Health Policy Board, which we kind of rest under, can comment on legislation, can introduce legislation. That's in their enabling legislation. For us, We could maybe send a recommendation to the health policy board. We could send a recommendation to the governor. We can do those things, but we can't show up and say the cost growth advisory board thinks X, Y, or Z in the legislature. I mean, we could, but I like Sarah and I'd love for her to continue to work here, as well as Andrew. So let's just not do that. But as individuals, please submit comments. And as we go through the meeting, I can actually put the committee link in the chat on how to testify in a public hearing or committee so that people can get that and submit comments on their own.
Great, thank you for that response.
And I think if the committee does want to talk about sending a letter to the policy board or encouraging the policy board, our policy board liaison, Bill Kramer, can't be here today, but I'm going to meet with him in the next couple of days to give an update on this meeting. And if that's something that the committee would like to move forward, that's an option.
Yeah. Okay. All right, Sarah,
Back
let's
to data.
do
All
the
right.
show. Let's go to the data. What we've all been waiting for.
I apologize also in advance because I feel like I'm going to be talking a lot in this meeting. So, Johnny, can we go to the next slide? And then one more. So, Felisa covered a lot of this background, but just to quick regroup, we've previously been looking at a 2013 to 19 measurement period. That was our pre-COVID sort of baseline. We did a lot of analysis from our all payroll claims database to understand cost trends and cost drivers using a total cost of care approach. That was only claims data. So we are now going to switch, and the data we're going to talk about today comes from our cost growth target program data submissions. So as part of the program, every year, we identify which payers have a sufficient number of covered lives in Oregon, and those payers are required to report data to the program. That data is total healthcare expenditures. So it includes claims spending, non-claim spending. It also includes public program spending. So how much are we spending on healthcare through the VA or at the Department of Corrections or through some other contracts that aren't necessarily running through the payers. And it also looks at net cost of private health insurance. So net cost of private health insurance is a pretty wonky term. We're going to use it a lot in our measurement. You're going to see NCPHI in a lot of the graphs I'm about to show. NCPHI is the difference between what a payer collects in premiums and what they spend in payments on claims or for services. So it's sort of the admin, it's where things like some of the operating costs are budgeted out of. It's where some of the profit or the profit margin would be, but it's broader than just profit margin. So it's a pretty important piece of the spending puzzle, and we're excited to break it out. It's called net cost of private health insurance, but we can look at it for all payers. So Medicare Advantage and Medicaid CCOs, as well as the commercial insurers. So this is a different data source. I can't say that enough. We've been looking at claims and now we're looking at other things. So the level of insight and the questions that we can answer out of this data are a little bit different. And I think as we're going through this, one of my goals in presenting this data to you today, we have not actually published this yet. These slides are the first time this data has been shared publicly. And so I think last time we shared data with you, we shared it after publication, and you all had some really great questions and comments and was like, oh, we should have put that in the report. So I'm hoping that today we can share this as a preview, as some highlights, and that your questions, your comments, your places of like, well, why is this true? What happened here? Go dig further, can really help us shape the final brief before we publish. So wanted to just really welcome your comments about this data or your questions about this data, because it'll help us shape the final product. Okay, next slide. Like I said, this is from the cost growth target program data submission. This is calendar years 18, 19, and 20 data. And the last background caveat is that we are only going to talk about cost growth for this measurement period at the state and at the market level. So Medicaid, Medicare, and commercial. We had previously agreed that we would not publicly report payer and provider organization level data until 2020 to 2021. So that's the data we're getting ready to publish in May. So pretty close, you know, in getting these reports out together, but we're getting really close. I just want to say that we do not have payer or provider level data in this deck today, and that's coming as the next phase. This is all data that was submitted in fall 2021, and then the team spent, depending on how you count, I don't know, 6 months validating it with all the payers and providers. So lots of meetings, lots of back and forth about the data, about any abnormalities in the data. So there was a pretty long process, and those of you who are payers and providers were part of those conversations. So thank you. Okay, next.
Sarah, can I just jump in here? Sorry, real quick. I think as Sarah goes through these slides, I just want to remind for the public, if there's public comment or thoughts on these, please note that there'll be time in the committee meeting for that, and there's always time later. So since it's the first time people are seeing them, don't panic that this is your one shot at commenting on them. And a report to come. So please note that we're always open to getting that, and you can also send that between meetings as well. Sorry,
Yeah.
Sarah.
We would love your comments or questions on this data. If this is the first time you're seeing it today in this meeting live, feel free to reflect and follow up over email later. That would be great. So, okay, I'm gonna start with some high level total dollar amounts. So in this presentation, in these data slides, we're gonna switch back and forth between total dollars spent in Oregon and then a per person per year spending amount. So I'll try to note when I'm switching back and forth between them, but there's reasons that we look at both. We want to see what the overall growth is, what the overall impact is to the system, to the state sort of economy. But then we also know that as more people are in the state, of course, we're spending more because there are more people getting services and being covered. And so we want to standardize that and look at it on a per person basis as well, because that gives us a little bit more of an even comparison. So I'm going to bounce between those two, but we're starting off with total healthcare spending in Oregon, and this is in billions of dollars. So by 2020, calendar year 2020, healthcare spending in Oregon was just under $30 billion. That's an increase from $27 billion in 2018. And that's a pretty steady increase. So I know that we've talked a lot, and we will talk a lot about how there's a dip in 2020 on from that COVID decline and COVID utilization, and that's all true. And also our total dollars that we're spending are continuing to increase year over year. And then finally here, total healthcare spending as a share of our state's gross domestic product was 11.4% in 2018, and it increased to 12.2% in 2020. So that's in line. There are national increases, national calculations of that increase as well. They include some different things, but the percent growth is pretty similar. Next slide. Okay, so here we are still looking at total healthcare spending in Oregon in billions of dollars. So this is the total amount spent. And now we're going to start breaking it down by market. So in each of these bars, you can see that we have the total dollars spent for commercial, Medicaid, and Medicare. You can also see that dark blue bar at the top, which is the net cost of private health insurance, again, which is not just commercial, it also includes Medicaid and Medicare. And then at the very bottom, there's a lighter blue bar that's other public. And so that is where we collect some supplemental data like the VA or how much we're spending on behavioral health contracts outside of a payer and some other things. So you can see here both the total dollars in billions spent in each of those calendar years by market. And in the bubbles in between the bars, you can see what the percent growth was for each of those categories. NCPHI is the net cost of private health insurance. Thanks for that acronym check. So there's a lot of data, a lot of information in this graph, depending on what you want to look at. I think one perspective is you can see that commercial and Medicare are some of the places where we spend more money. They're larger shares of the pie. But you can also see what was happening with the growth between the years. So one thing that I want to start off with here is that between 2019 and 2020, we see a really big growth rate, 36.7% in the net cost of private health insurance. And this is where we start seeing those COVID impacts, where this is likely because there was less utilization happening, payers were not paying out as many claims for services in 2020, And so we see a growth rate, pretty strong growth there. We see some of this being adjusted in other ways through non-claims payments, and we'll get into that detail, but at a high level, this is what's going on. You can see that between 2019 and 2020, commercial and Medicare spending declined slightly, as a percent growth declined slightly, and then Medicaid increased. This is, again, likely COVID related, as more people stayed on Medicaid, as redeterminations were paused. We likely see some continued growth there. I'm going to keep breaking all this down, but I know there's a lot in here. So any immediate questions or reactions to this graph?
Okay, I think people might be saving it up or just digesting, but
That's fair.
oh, Stefan.
All right, I'm going to keep going then.
Oh, wait, we had Stefan.
Oh,
Go
yeah,
ahead.
sorry, I forgot to blow my hand.
That's okay.
Could you
Jump in.
Yeah, I'm just curious about that increase in the NCPHI bucket between 2019 and 2020.
Yeah, so our best explanation and what we are pretty aware of from multiple data sources is that utilization declined in 2020 for a variety of reasons related to the pandemic. And because utilization declined, there were fewer claims to be paid out from the payer perspective. And so because net cost of private health insurance is the balance, it's the difference between what they take in premiums, or on the CCO side, global budgets, and then minus what they pay out in claims or non-claims payments. So to the extent that they were paying for fewer services, that grew. I think I would ask if any of the payers on the call have any comments or perspective to share here.
Yeah, Sarah, I'd want to look at the detailed calculation of that and kind of bounce it off of the reported profitability of various entities. I don't recall that kind of pop in 2020 across the industry, and when one would think there was probably a fairly substantial increase in some costs related, some admin costs related to COVID. So I think that's going to be a really important number in the future to break down, so that we can speak to whether it was increased cost, increased profitability within the industry. And then to be able to add 21 in there will be really interesting, because that's when the deferred payments hit. So yes. I think we're at risk a little bit of washing it all the way down to, oh, COVID costs less and therefore that created profitability. I think there were a whole bunch of moving parts during that period of time. And if we're going to communicate to the public what really happened, we should probably get our hands around it. The other comment I would have as you go through this is that COVID created some fairly interesting shifts in demographics. And as we start thinking about per member demographics in each of these or per member costs in each of these categories, we should be aware of demographics. The cost of a child under the CCO Medicaid program versus an adult member who was not redetermined. And so some of the shift in that could create some very substantial shifts, and you may be seeing that in that 21.7%.
Yeah, and I want to also comment, like, I think we often talk about NCPHI, net cost of private health insurance, and we sort of shorthand that as profit, but that's not accurate. There are more things in that category, and it is more complex than that. I also note that sort of if you take a longer historic look at NCPHI, it bounces around, because it's also partly based on how well an insurer can predict their costs and how they've set the premium. And so if you do a really good job setting the premium to align with true costs, your net CPHI is going to be really small. It's going to be really tight. If you over forecast, then you will collect more than you need to spend and your net CPHI will be high. So I wouldn't necessarily assume that it's going to be up and, this means everyone made a lot of money. It does bounce around year over year. And I think we'll see, we'll have to see what happens in 2021, 2022 as we keep going. But yeah, I thank you for calling that out, Peter, because it is really easy to shorthand that as profit, and that it's not just profit.
Let's jump. I have Mary Beth and then I have Steph.
This is an unrelated question, so if folks still have answers to that question, I'm happy to hold.
I think, let's go, Mary Beth, and then.
Okay. So I just, and I'm sorry if I missed this, Sarah, but the increase in Medicaid from 2019 to 2020, is that or could that in part be due to the fact that folks were not being redetermined off of Medicaid?
Absolutely. Yeah, we're covering more people. And so this is that split that I was talking about a few minutes ago about this is the total dollars spent. So if you're covering more people, you're going to spend more money. And we're about to look at a per person growth, which will standardize that a little bit more. But yeah, absolutely, redeterminations are factoring in here for the Medicaid growth.
Great, thanks.
Or the lack of redeterminations. Sorry. Stefan.
Yeah, sorry, I think we're bouncing back. So just to get that clarified, because you don't have it in like separated out in previous slides, and when we looked at these cost buckets by markets or payers. So can I think about that the NCPHI was included in the commercial in the previous?
No.
Or is that, so it was not in there?
It was, sorry, the previous slide was just the total dollars spent, which was all of these added up.
Right.
So, yeah.
No, I'm referring to like slides that you shared like in previous meetings, right?
No. Those slides were only claims-based spending. This is not a direct comparison because now we're looking at so much more of the dollars. No, that was just claims previously.
Okay, so this is a result of what you said, the different data sources. Okay, thank you.
Yeah, I know this is really wonky and I'm sorry for that. So trying to keep everybody like with me as we go. Let's go to the next slide and start talking about things on a per person cost. So again, we're now switching, this is per person per year. So looking still at the total per person, this is statewide across all markets. We saw about $8,100 in 2018, going up to $8,400 in 2020. Noting that Oregon has a lower per person cost than nationally in general. So we are still doing good, especially on that, on that front, as you compare to maybe some East Coast states, some more expensive states like Florida. But this is the per person average here. So we saw 3.7% growth between 18 and 19 and a negative 0.5% decline drop between 19 and 20. Again, COVID, this is all rolled up at the very highest level, and there's a lot of variation by market and by service category that we're about to get into. This measure, the total healthcare expenditure per person per year, this is what we compare to the cost growth target. So even though I'm sharing percent growth, and when we talk about the billions of dollars, we're not comparing the billions of dollars to the cost growth target. We're comparing the per person per year spend to the cost growth target.
Lawrence?
Thanks. And again, this is riveting data for those of us who love numbers. Just a point you made there that I think is just really helpful for us to keep in mind when we compare Oregon's growth per person to national statistics, to do both the dollar increase and the percent increase, because sometimes the percent increase can be higher, but the dollar increase can be lower because we start so much. And so it's important just to include both of those. And I think this chart does a great job of doing that from a Oregon specific perspective. But when we add the national comparisons, I think that would be great.
Thanks for that validation. It's a little tricky to jump back and forth between the two, but I agree it's really important to have both for the full story.
Lawrence, as we think about your comment, as we see more and more as pharmacy takes more and more of the total healthcare spend, we cannot control the cost. It's much more a national cost, and we will trend towards the national overall cost of healthcare, trend towards it, not reach it necessarily. But that will show that we have a higher growth percentage that can't be impacted necessarily by the folks in this room. And so, Lawrence, I really like that idea to be able to show both total dollars spent versus national average as well as trend.
Well, I want to jump in and say, Peter, we're going to talk about pharmacy later, so don't give up on us just yet.
I'm excited about that piece. I think I'm leading that discussion.
Sarah, go ahead.
Okay, let me keep going because I definitely want to get us to some of the service category specific data here. So, okay, this is the total per person per year spend across all markets. Let's go to the next slide. This breaks out by market. So we're still looking at per person per year in Oregon, 18, 19, and 20, commercial, Medicaid, Medicare, and again, dark blue, you can see the NCPHI, net cost of private health insurance growth. So this is something we've seen repeatedly. We saw this in the claims data as well. Medicare members are more expensive. We spend more on care per person for Medicare than we do for the other markets. Medicaid is a little bit below commercial, but you can see, again, it's just a fraction of what we spend on Medicare. And this is true nationally. This is very, expected in the data. We'll note a couple of things here. The benefits that are available to each of these markets are not standardized. So Medicaid, this includes different costs than it does for Medicare or commercial. So just reflecting that there are reasons why we spend more or less in certain markets. There are also various federal and state limitations on how much things cost that factor into this. But at a high level, big picture, we spend a lot more per person for Medicare members than we do for commercial and Medicaid members. And we are still seeing growth generally across all markets.
Sarah, I have a question here on these, on the market pieces and the per person spend. Is there a way to break out commercial between the exchange lives and the broader commercial market?
I'm gonna say no off the top of my head, but I want to check with the team. We can do that in our all payer claims data. So the previous data we could have broken out this way, but not the data submissions from payers. We're rolling those all up together.
Okay, great.
If that's something of interest, we can dig in a little bit more, but it's not a direct breakdown from this data source.
I think it will be, I think that will be answered once we get to the breakdown in the more breakdown in the payer provider data. So I don't think it's necessary to spend a bunch of staff time digging into that. So, but I appreciate the answer.
Okay, thanks.
Hey, Sarah, this is Julie. Could you just remind me how the commercial data is collected? You said it was by survey. Is it surveying employers? Is it surveying insurers?
It is a mandatory data submission for all payers in Oregon that have at least 1,000 covered lives. So for any payer who operates in Oregon, whether that's a domestic payer or a national payer, if they have 1,000 covered lives, we send them a letter and say you are a mandatory data reporter and you need to submit data in this format by this date. So this is a data submission that we're collecting specifically for the program from the payers.
And is it just a paid amount or is it allowed where it includes member cost share or per person cost share?
It's not a claims calculation in the same way, but we are looking at allowed amounts for the most part, especially in the commercial market. There are some nuances that I don't really want to get into today, but generally it's allowed amount, but it includes how much the payer paid to the provider plus the member cost sharing.
Okay, thank you.
Okay.
Then I have one more question on this, on the market question that I think maybe is a follow-up from Julie's question is this does include our self-insured payers, or what percentage of our self-insured payers are included?
It includes some of our self-insured payers. So for our payers that have at least 1,000 covered lives in Oregon, we say, please submit your data. If they have fully insured lives, payers are including their fully insured and their self-insured sort of all together. If they are only self-insured, we can't require them to submit data. If the only market they operate in is self-insured, we have sent all of those self-insured payers a letter inviting them to submit data, and we have had very low take-up / non-existent take-up on that front. So we are definitely missing some self-insured, but to the extent that we have large payers that offer both fully and self-insured plans, we have that self-insured data.
Great. I feel like it would be great if at some point DCBS could answer the question of what we believe is the percentage of the self-insured market that's reporting.
We can work with DCBS and come up with some estimates there.
Okay. And then there's there's a comment in the chat from Michael. I know it's hard to see the chat right now, so.
Yeah, Michael is asking when or how do we overlay or understand quality of life or patient satisfaction in relation to spending? So spending and quality, and how is that moving together or not? I think at a very high level, I would say that part of our charge for this program and part of the charge for the committee is to have that lens. And so I think we do want to be reporting quality data in the future alongside this. We do want to be looking at satisfaction data alongside spending. We don't have it here, but I think that's part of what we intend to roll into reporting in the future. We're not quite there yet. I think when we start reporting at the payer and provider organization level in May, that gets easier because then you can start saying, you know, where do we want to look and what do we want to look at quality? And it is related. So access, if you have low access, you know, if your quality measures related to access are low, that is likely going to be reflected in spending because you're just not seeing as much utilization because people are not accessing care. So I think there's a lot for us to dig into here. I don't think we're quite ready for that. So I don't know if that's a very satisfying answer, but I think it's part of the long-term trajectory.
I think we definitely, I mean, we'll continue to put a pin in this, and I think it goes to the equity subcommittee as well. So let's go, we'll go Gil and then Lawrence.
Yeah, hi, thank you. My question was really on the Medicare side, and I'm just curious, what percentage of our Medicare is in Advantage plans as opposed to versus you know, straight Medicare, and do we see differences in costs from the two?
Yes. So ballpark, I think our estimate in Oregon has been about, it's like a little over 50% or around 50% are Medicare Advantage. And that was high compared to other states. I think that's starting to shift nationally. More and more Medicare members are enrolling in Medicare Advantage plans. And so I don't know how we stack up nationally anymore, but sort of historically, we've been a strong Medicare Advantage enrollment state. In terms of when will we start breaking that out, that will be in May, because for us, we consider that as sort of the by payer. So we'll be able to break out specific Medicare Advantage plans by payer, as well as Medicare, original Medicare, Medicare fee for service. So we are planning on reporting that, and there are differences, absolutely.
Lawrence?
Yeah, just again, great data. Just a quick comment on, I sound like a broken record, I know, but this is obviously the price of healthcare, what's paid to it. If you look at the underlying providers, so for example, in the OHA webpage on the hospital database, you see that you know, commercial payment rates per dollar of gross charge, for example, you know, tend to run 2 to 3 times the Medicaid one, whereas the paid amount is about the same. So the underlying cost, at least on the hospital side, is significantly different from that perspective. So just another overlay.
Lawrence, are you reading ahead to Sarah's next slides?
I may be. Okay.
All right, Sarah.
Thank you. This is great feedback and engagement. So I think these are exactly the questions on the charge of the committee, like where do we unpack and how do we bring in that price versus utilization or the paid amount differences between markets. But again, this is just total spending by market on a per person basis. So, okay, next slide. Okay, this is the same data that we just saw, but now looking at the percent growth. So on a per person per year by market, here's what the percent change looked like between the years. So between 18 and 19, we saw low-ish growth, you know, pretty close to our 3.4% target if that target had applied in this period. And then 2019, 2020, again, you can see the big change. We see a negative growth rate between 19 and 20 for all 3 of the markets, likely COVID related. This is again that drop in utilization that we all know happened. And we see a big jump in the net cost of private health insurance. Again, if utilization wasn't happening, payers weren't paying for services. And so of course that part of the pot increased. And I think this is going back to that earlier point of how it's really important to look at the difference between the dollar amounts and the percent growth, because here this looks very stark, like, oh my gosh, we have a 28% growth in NCPHI between 19 and 20. But if you looked at the dollar amount, it's actually a lot smaller. I'm trying to go back to the last slide. So, we're talking about $1,000 per person per year here, and the growth was, it's about a $300 growth. So 28% growth versus $300 per person per year. So wanting to keep both of those in mind as we toggle through this. Okay, next, one more. Okay, so pivot. We are now going to look at a subset of this data. So before we were looking at claims, non-claims, net cost of private health insurance, and other spending. Now we're just going to look at claims and non-claims. So the total medical expenses, this is how we're going to measure at the payer and provider organization level, because these are the parts of healthcare spending that are flowing between payers and provider organizations. So there's a lot in each of these categories. So claims, this includes all of our typical hospital inpatient, outpatient, retail pharmacy, long-term care. Non-claims are all of the other payments that payers are making to providers. So this includes capitation, so prospective payments, global budgets. It includes any incentive payments that are made. It includes support payments that are made, other investments. So for example, when a payer might support health information technology or electronic health record for a provider organization, that's where those dollars are captured. This is where we're going to start talking about pharmacy rebates. So one of the previous notes / criticisms about our claims analysis is that that was just looking at the amount on the claim, which does not take rebates into account. This data that we're collecting from payers does. So we're going to be able to look at retail pharmacy gross and net of rebates. Okay, next slide.
And I'll just note in the chat, Sarah, I think if people have ideas for the report as we're going through, that's a great place to put them. I think Lawrence kicked that off. And so other folks were like, we had a lot of questions about that. I think we should add something to the report. Please drop it into the chat and I know the staff will take those notes. So
yeah, please. Thank you. Okay. So we are now going to look at the total medical expenses. So again, this is just claims and non-claims. We're taking NCPHI and other spending off the table. And we're breaking it down here each year. In the dark blue, we see the claim spend, and in the gray, we see the non-claim spend. The graph on the left is gross of pharmacy rebates. The graph on the right is a net of pharmacy rebates. And we'll talk more about pharmacy rebates on the next slide, but I think just at a ballpark, a couple of things that I want to share with you here. My takeaway points are, even though we are seeing a lot of growth in non-claim spending, we still are spending the majority of our dollars in claims. That's still where our system is going, despite our push for value-based payment, which would all be captured in non-claims categories. The bulk of the dollars in Oregon in the health system are in claims payments. You can see that we did see that growth between, we have that triangle spike where we see an increase in claims in 2019 and then a drop again in 2020. Again, that's the utilization drop. And you see some of that being mitigated by the non-claims increase. So there was a 14% increase in non-claim spending between 19 and 20. And again, we're seeing billions of dollars and the percent growth on this. So again, a lot of data throwing at you here, but top line, most of our dollars are in claims spending. Decline in utilization and spending in 2020 as expected, and some of that counterbalanced by increase in non-claims. Next slide. So to dig into the pharmacy rebates a little bit more, looking across those 3 years statewide, we saw about $2.5 billion in pharmacy rebates. I want to note that this is just the rebates as reported by the payers. That does not necessarily mean that the payers accrued those rebates. So rebates can be complicated, pharmacy rebates, in terms of where they go. Do they go to the payer? Do they go to the PBM, the pharmacy benefit manager? Do they go to the patient? So this is what's being reported, but we still don't have sort of that pinpoint precision of where in the chain those rebates are. $2.5 billion across the 3 years, that's a huge amount, but as a percentage of gross pharmacy, this is where it's pretty interesting. So statewide, about 21% of the cost of retail pharmacy is coming back in rebates, but that really varies by market. Most of that is being driven by Medicaid. So that's the green bar. And I was actually really surprised when I saw this, and I have a ton of follow-up questions that we're going to be working on, because previously I had heard, sort of the working assumption was that Medicaid was getting about 50% back in rebates. So this was a lot higher than I was expecting to see, and I have questions. But you can see that Medicaid is driving the bulk of the rebates, and that's partly because of policy, and Medicaid can negotiate in certain ways, and there's a bunch of things that are structured to set that up. Medicare and commercial rebates are a little closer together, under 20% in both markets across years. Any questions about these two slides or comments? Okay, next, I'm going to keep us going because I know I'm running out of time. Next slide. Okay, so now we're taking non-claims off and we're just looking at claims. So this is just the claims-based spending statewide across all markets in billions of dollars by service category. So we can group claims into various buckets, and we can see how much of each year's spend they were, as well as how the costs are growing for that category between years. So at the bottom of the graph, you can see hospital inpatient and outpatient. There was growth between 18 and 19, and then a decline between 19 and 20. Same story as expected. Professional services are the next biggest category, sort of across the middle of the graph there. Again, increase between 18 and 19, decrease between 19 and 20. Professional services is a pretty big category. This includes a lot of sort of doctor services. So your primary care visit, your behavioral health visit would be all included in that. Retail pharmacy, we just talked about, and we're now talking net of rebates. So all the rest of the slides are going to be net of rebates. We also see long-term care and then other. Next slide. So this is the same data we just saw, but now we're breaking it out by market. So these are the same claims-based categories and the growth between 18 and 19. There's too much data to fit on one slide. So 18 and 19 on this slide, 19 and 20 on the next slide. You can see that we see there are some places that definitely pop out. One more thing I want to say about the data here, the way we collect the data statewide includes Medicare fee-for-service data. We get that directly from CMS. We cannot break it down into the professional subcategories that are highlighted in gray. So the Medicare column is only showing Medicare Advantage, even though the statewide includes Medicare fee-for-service as well. So again, really wonky, sorry about that, but wanting to explain the difference. And we thought that it was really important to have that detail because there's a lot that's different between primary care and specialty and behavioral health in terms of the growth highlighted in that gray section. And we lose that nuance if we're just looking at professional rolled up together. So for example, commercial professional behavioral health grew 18%, while Medicare Advantage saw a 9% drop between 18 and 19. So major variation there between markets. Okay, and then the next slide is the same information, same markets, but between 19 and 20. Gerondy, one more slide. Yeah, okay. So now you can see a lot of those bars have shifted and we're now seeing negative growth between 19 and 20. Again, as expected, this is the claims categories. A lot of this is based on utilization. If people are not going in and having outpatient or inpatient services, of course, we're going to see that drop in spending. Some weird things in this data. We do see a pretty big jump in commercial professional behavioral health between 19 and 20. Interested in what's going on there. That could be good. This is one of those, not all spending is bad, but maybe that means that more commercial members were able to access tele-behavioral health services during the start of the pandemic. That would be a good thing. We also see a really sharp drop in long-term care for Medicaid. And we have some questions about that we're exploring internally. We're not quite sure what's going on there. So that was surprising to see and don't have a good answer yet. But again, I think the overall story is there was continued growth between 18 and 19, and then COVID hit, and we saw the drop in spending that we all expected because of the pandemic. Questions on the claims categories?
Peter?
Thank you. I don't know where the button is for my hand raise. I would take a look at the Medicaid rebates as a total of the percentage. That number doesn't resonate with what we see in the marketplace. So you might want to, tie that back to Exhibit Ls or something that just as a test, that number seems a little wonky.
Okay.
And it may be pulling off gross, not allowed, and et cetera, something like that.
And we have a lot of chat discussions here. I know it's hard for you to see, so I'm just gonna run through pretty quickly. I think that Lawrence thought it would be worth adding a subtotal of commercial plus NCPHI as another data point. I asked to do a market analysis. Gil would like the cost broken down with performance categories, which I think is a great idea. And yeah, everyone is very interested, I think, in this behavioral health for commercial plans, especially given what we know has happened during the pandemic. And so Tasha Sizemore put that in the chat, and then Lawrence has a theory on the difference between the 10% drop in Medicaid IP hospitals versus the 2% commercial. So I think we're running very behind. And we want to talk about pharmacy. So I'm going to let you breeze through, Sarah, and then we're going to jump to another incredibly meaty topic. So,
Yep.
thanks.
I think, Lawrence, to your point, yes, absolutely. Some of this is deferral of procedure. I think we can't tell if it's just how much of a drop in utilization is due to a deferral or not. But I think as we add back in 21, 22 data, we'll see how much of that comes back. So I think lots of questions, please keep them coming. I want to share one more data slide and then we will move on. Next slide, Johnny. So I want to share the breakdown of the non-claims categories. And I think this is going to get to Gil's question about the performance incentive payments. So here we have the categories, they all fit on one slide. So top 3 rows are 18-19, bottom is 19-20, same markets, and these are the non-claims payments. So prospective payments, that's things like capitation rates, global budgets, performance incentives, that would be any sort of quality performance payments. There are lots of things that are rolled up into that category. I've removed a few of the smaller categories here just because they were pretty much zero, but we'll have them in the full report. So I think to the question about performance incentives, absolutely we see a huge jump in 1920 where incentive payments were made. So for example, we know CCOs received their quality pool and were encouraged to distribute their quality pool to provider organizations as a funding support early in the pandemic. And so that's definitely being reflected here. Okay, I'm gonna stop. We are working on putting this into a public-facing report. It's not quite ready for prime time, so great comments, questions, feedback, keep them coming. We do want to get this out between now and May, so coming soon, and we'll share with you when that's all available. But yeah, thank you for your engagement on this. I'm really excited to see your excitement and questions.
Gil.
Yeah, I know we want to move on. I'm just curious on the population health. Can you just describe a little bit more as to what's in that category?
Yeah, so it's a pretty broad category, and it can include things like payments or investments that were made to support population health or health equity. It can include technology investments. So for example, we know that there are some payers who actually pay for all the providers in their Medicaid network to be on the same EHR. So that kind of payment would be reflected in that category. It really, in some ways, it's really up to the payers on how they categorize. We provide some guidance, but there's a lot of nuance in some of these categories where they roll up and include a lot of things.
So that could be an encouraging sign if people are moving to for infrastructure to do better on value-based pay and value-based care. Yeah, okay, thanks.
Yeah, hopefully. And I think we'd see that the value-based payment compact and those targets would be reflected in all of these categories, depending on the type of value-based payment arrangement. Some would be in prospective payments, some would be incentive payments, some would be support payments.
So I think as we think about this report, there's additions in the chat from Melissa as well on charity care and financial assistance. Which is a separate OCHA report, but maybe a little bit of merger here. I think I do think we are going to have a very robust discussion in May when the provider numbers come out, and I do want to just put a pin in. We're going to talk about pharmacy today. But we've had many discussions on value-based payments. We'll need to circle, I think, back around on those strategies that we're discussing in that May, and as part of that May conversation as well. And thinking and looking at this data, I think digging in a little bit when the report comes out, digging a little bit more to think more about how are we thinking about strategies, knowing the changes in the healthcare environment, et cetera, that we can discuss in May. So I'm gonna hand it over. Do we want to keep rolling or do we want to take 5 minutes? Because that was a lot of stuff. Knowing that we're behind. Okay, I'm seeing a thumbs up for 5 minutes from Lawrence. So and I'm seeing blank stares from a lot of people. So that says that we should take 5 minutes. And I'm going to come back on here at 5 minutes and be very loud for you to come back. So we'll take 5 minutes and come back.
One more.
And probably one more. Felisa, are we ready?
We're ready. So folks
All right.
can jump back on and get
Thank
ready.
you all.
to dig
Sorry.
into pharmacy.
So sorry for the short break, and thank you for the really good discussion. We're just barely scratching the surface on those trend reports. I would ask that people remember that our task is to think about annual trends, and that we have this 3-year period of COVID 2020 through 2022 that didn't work in 3-year trends. And I think it's our job to help people understand that 19 through 20 is going to look very different from 20 through 21. And then even into 22, there were some very substantial costs in the winter of 22 related to COVID, related to hospitalizations. And I think if we can bracket all of that period of time and think more about averages as well as annual, because that is our task, it'll be important to communicate sort of what happened in COVID, in addition to how do we get back on this average 3.4% trend. Speaking of 3.4% trends, we've just seen some new data on pharmacy costs, even net of rebates, and they're growing from 19 to 20 at about 7%. Now think about the 22.5%. That's a rough number. It varies by line of business, but the 22.5% of our total healthcare costs that's spent on pharmacy, at least relative to claims, maybe not total healthcare costs, but relative to claims. And then you put a 7% on that, that eats up 1.5% or a little more of our 3.4%. It really puts pressure on our providers in this structure. So this is an area we've got to get our hands around. In addition to that, you obviously have cell and gene therapies. You have the new GLP-1 class of drugs that are coming on the market. And those are the weight loss drugs that are going to have some really substantial cost impacts. So what have we done? In July of 2020, we looked at pharmacy costs as a key driver in Oregon. In 2022 meeting, we talked about sort of the menu of potential state and federal policies that could address this issue. In November, we started looking at, is it price or is it utilization? I would probably say the conclusion was yes. And then in the last meeting, Ralph was kind enough to really bring us the information on the prescription drug affordability board work, that report and our review of that report and approval. As you may recall, the PDAB, that's hard to say for me, is statutorily required to communicate their information to the cost growth target program, and they do that through our committee and through the approvals that our committee gives. So let's go to, I don't know if I'm the next slide or you are, Sarah.
I can take this. This is a little more logistics. So at the January meeting, we were having this conversation about the Prescription Drug Affordability Board recommendations and some conversation about where do we go from here and where does the committee want to dig in with an end goal, I think as Felisa and Peter have said repeatedly, of how are we identifying some strategies? How are we really figuring out how to address some of these cost drivers? And I think at the time there was maybe a little bit of confusion and a little bit of like, well, we don't really know where to go next, and we're not really sure what would be most helpful or where the conversation should go. So what was proposed was a survey that would be open to the advisory committee members and other interested parties to help prioritize or to help, give us a little more structure for the conversation about pharmacy strategies. So we put together a survey structured around all of those different groups of strategies. It was open to the committee and other interested parties. We sent it out to you all and to our technical advisory group distribution list, which is a lot broader. And it was open for 2 weeks in February. So I think I'm going to try to catch us up on time, and I'm going to give us the very high level of the survey findings. There's a lot of detail in the slides about what questions people had about the strategies, and so that's all there for your reference. But I think I'm just going to sort of summarize where the priorities shook out, and then give it back to Peter for some more open discussion. So next slide. I think this is the top line findings from the, 24 responses to the survey. Half of them were from committee members. Most of the respondents were from health plans and payers, although we did see respondents from other entities across the system. Next slide. Okay, so this is the takeaway. So in terms of which strategies respondents are most interested in, transparency and affordability review strategies by far is the leader here, and coupons and cost sharing strategies are the least are of least interest to the committee. So transparency strategies, these are things like requiring entities to report information such as explanations for price increases and requiring reporting on changes in drug pricing. This also, this really aligns with the Prescription Drug Affordability Board recommendations about creating more transparency into that supply chain. And 96% of respondents wanted to know more about this area. The second area that was of most interest was around importation and volume purchasing. So this is around advancing wholesale prescription drug importation from other countries, state opportunities to leverage collective buying power and better coordinate drug purchasing, which could be things like purchasing consortiums, which Oregon has and is part of, and bulk purchasing. And 88% of survey respondents were interested in this area. So, Gerondi, let's go to slide 35. Again, all the details here for you to read. Keep going. Okay, this one. So this is a beautiful graphic that one of my team members made. And I just wanted to share that there was a little bit of a difference across the respondent types. So you can see each of the strategies here is a different color. And we saw the payers and CCOs were a little more varied in terms of where they wanted to know which strategies they thought would be most helpful. Consumer advocates, employers, and purchasers were interested in learning about everything. So to the extent that that might be helpful information for you, just wanted to share that the respondents did have some differences in terms of which strategies were most relevant. And I would suspect, I'm going to totally editorialize, that that's based on where you sit. Some of these strategies are things that payers can definitely do, or that could be implemented at the payer level. So it makes sense to me that they would have a more narrow focus on certain strategies than someone who might be more broadly interested in how do we address pharmacy costs. Okay, and I have one more slide that I want to share with you before discussion. Next slide. Wanted to just share, sorry, one more. Where Connecticut is going, because Connecticut is a cost growth target program state. They're about a year ahead of us in terms of the timeline for implementation of their program. And they are also very focused on pharmacy costs and identifying strategies to mitigate pharmacy cost growth. In 2023, they have a specific goal to recommend practical, implementable cost growth mitigation strategies for pharmacy spending and hospital spending. And a couple of highlights. In October, they reviewed the state legislative landscape for addressing prescription drug costs. In November, they've launched a work group to dig in. It's sort of a subset of their committee. In February, the governor introduced some legislation that would address bulk purchasing and some additional transparency. And then later this month, their pharmacy cost mitigation strategies work group will be presenting recommendations back to their steering committee for potential adoption. So I don't know what's going to come out of that work, but we're definitely keeping a pretty close eye on their recommendations because they're just a little bit ahead of us in the timeline and making some tangible progress. And we share pharmacy as a major cost driver.
Sarah, do you know the makeup of the Connecticut Committee on Cost Mitigation and how that compares to our PDAB? And is there any learning that we could take away from that?
I do not know off the top of my head. That is definitely something we can find out and report back on. And I would say that this is their pharmacy cost mitigation strategies work group is a subset of their cost growth target steering committee. So it's a subset of their counterparts to you all, not a counterpart to their prescription drug affordability board.
Interesting. You know, I think it's indicative of the survey that says transparency is probably the number one issue for folks. This area is so opaque that for lay people who don't live in this work every day, and that certainly includes myself, it's awful hard for us to figure out where the leverage points are. So I do think that we need more and more opportunity to lean on some folks that think very deeply and often about this work.
Okay, I think, Geronda, can you take the slides down so we can have everyone's faces up for discussion? And I think, Peter, it is back to you to take us, figure out where we're going next.
Isn't that the question? So where do we go from here? Is there an aggressive approach? Are we supportive of an aggressive approach? What's the path for the recommended strategy as we move forward? Gil?
Yeah, I think as we're thinking about strategies, what I'm often, thinking, well, what requires a national fix, and what can we do at the state level, so it might be helpful to know, what's allowable, for a state to act on its own or in coalition with other states or regional approaches, as opposed to what needs a fix at the congressional level that may be much harder to do.
Yeah, I think that would be a tremendous benefit for this group to have a really clean list of what can we do through the state and what can we suggest that the state do through the feds. Sarah,
I
did
just
you-
want to plug in the chat that we tried, I think we tried to start the conversation there by creating a menu of what are things that require federal intervention and what are things that might be under state control. This is a new angle of where could states specifically request something of the feds, and I think we could add that to the list, but it might be a good time to have folks look back at the November slides where we did break out what could be done at the state level for these various categories.
Sarah, for this discussion, is there anything you'd want to review quickly out of those slides?
Yeah, absolutely. This is like a pop quiz for me. Hold on just a second while I scroll frantically to the right place.
While Sarah does that, I feel like this whole meeting has been a pop quiz for Sarah, and she's killing it right now. I just want to, I actually want to plug at a very aggressive strategy on this topic. I want to, on the pharmacy topic. And I want to say that I actually think as a state, we should take more risks and push the federal law to its full boundaries. Because I think, you know, I do feel like it's worth sort of walking right up to that edge and sort of seeing what happens. And I think if a lot of states, if we can have Connecticut and other states doing similar things, and we can set some of those boundaries, I actually feel that's how we are going to get federal movement on this topic. Because I think people have been really lobbying this for decades, and we haven't really seen that federal movement. So I think one of the strategies that I would like to recommend, and I'd be very interested to hear the payer and providers. By the way, this is just me talking. I'm rambling a little bit because I'm nervous to say it. Let's be honest, what's happening. I'm going to say something crazy, and I'd like to hear the payer providers, I feel like, jump in. Is there a way that we can work around the non-compete agreements and bulk purchase across our providers? And I mean in a very large setting. So, you know, Providence is one of the largest health systems in the United States. So is Kaiser. If we were able to sort of combine those, you know, Regents, Blue Cross Blue Shield, I think, you know, as part of a massive network, could we combine our purchasing across those payers on sort of either a multi-state or a multinational level that would give us the bargaining power to have a very different discussion with the pharmaceutical industry. And could we start that in state? I know we have the bulk purchasing. I think that's different than what I'm talking about. And could we do that across multiple states? If we were to suspend some rules in our state on this topic.
Thank you for teeing that up. I really, really appreciate it. I think it's going to be that level of thought process that is required for us to make any movement in this area. If we work around the edges, the changing in annual or sometimes 3 or 4 changes in pricing in a particular year by the pharmaceuticals eat it up. And so, Lawrence, before we go to you, I would like to have a lot of people weigh in on the concept of getting aggressive about pushing on some of the barriers that we've had over the last decades in this area. Lawrence?
I think it's a great idea to accumulate as much buying power as possible, pushing the edge using state actor immunity and other tools, and then buying in quantity and bulk and maximizing negotiated leverage. I would agree entirely.
Anybody else want to weigh in on that? I'll weigh in from the payer perspective, yes. I would also add that I've always wondered why the federal government has the ability to bar us from buying US manufactured drugs on the international market. So from an aggressive standpoint, that's always an area I've wanted to push on. So I'll add that to the list. Melissa?
Yeah, I'm nervous to say this as well. And I guess I wonder, we talk about this being an issue for decades, and the data that I've seen on what's being spent by lobbying from pharmaceutical companies, life sciences companies, is significant. And so there's another piece of this that is a resistance that I don't really think we're even talking about. And it goes actually, Peter, I think to what you said is, why aren't we kind of at a federal level able to access, lower cost in other places? And so I guess there's a piece of this too, when we talk about transparency, that I think could be valuable for this group to understand, is like, where is money coming from on that lobbying front as well, probably federally and even locally. That data is out there. I just don't know if it makes sense to look here, but as a part of the transparency, probably something would help inform why decisions are made the way they're made.
Yeah, I think, I think there's probably a political issue as opposed to a court issue in the rights. And I don't know how any of that works, to be honest with you. But I think more and more transparency around some of the dollars you're talking about, Melissa, can only benefit the situation. Other comments?
I have another crazy idea.
Melissa?
I also think the reality of the issue around patents, and the issue around patents on generics and other things like that, and the ability for other entities to challenge patents, I think is really difficult. And so I wonder if it would be worth talking to our Attorney General about creating a specialized department within the Oregon Attorney General's office to go after sort of patents and price gouging, and create sort of a level of legal expertise to challenge some of the things that are driving these costs at the state level, where you have sort of a consistent legal team who I think could do this in a way that is much more aggressive than an individual company, or, a small startup, or somebody, or frankly, a lot of nonprofits are the people who are challenging these patents. And, I work at a labor union, and we have more resources than nonprofits, and we couldn't challenge a patent, right? So, and I think, you have the industry, hospitals can't challenge a patent because they need those drugs, and they get punished if they try to do that. And insurance companies can't do it for the same reason. So the state, which is a neutral party, could have a whole legal department that is job is sort of this consumer protection when it comes to patents and when it comes to price gouging.
I think the aspect of consumer protection as an overall component is really an important one. And I think it kind of goes back to what Lawrence and Melissa, and certainly Felisa, has been talking about. Any other aggressive pieces? Because then I want to go to the other end of the spectrum, which says, what can we also work on that is within the current confines of the pharmaceutical issue? Anybody else have any other wild ideas? Where can we go within the confines of some of that work that Ralph talked about? And are there areas that you might recommend that we go to? Sarah, any thoughts that you had on this would be helpful as well.
Oh, I was just going to ask if there's anything from the purchaser perspective. So Julie, not to pick on you, Maybe I think Ali is on for PEB and OEB. Like, is there anything from any of those angles that we'd want to add to the mix? Maybe not.
Sarah, why don't you flip back to that surveys, or I've got the survey slide printed out here, so we can leave folks up. I just wanted to kind of touch on a couple of these areas. So within transparency and affordability, are there issues that we as a committee would recommend to the state, to OHA, that aren't available currently? I know this stuff is really complex and is not any of our subspecialties, so I appreciate the hesitancy, and I know it's a hard place for us to really create change.
So going back to the earlier question of what are some state strategies around transparency, I think the first two lines of recommendations tend to be whether or not a state has a prescription drug affordability board and a prescription drug price transparency program. Oregon has both of those. So we saw the PDAB recommendations. There's also a prescription drug price transparency program, and they have they have a recent report and recommendations that there are some suggestions in there on increasing transparency. I think starting with those lists of recommendations from those two programs are going to be very solid. There's a lot of discussion behind those. And then the third area that's sort of nationally, if you're thinking about what can states do in this area, the third area is to require supply chain participants to report things like profits, net prices, and rebates to create greater granularity. And I want to flag that some of the prescription drug affordability board's recommendations from December are currently in Senate Bill 404, thank you. That includes some of those pieces that would create some additional increased transparency. So I think we have a really solid foundation, and there are also some specific recommendations that are that have been proposed that are floating. So I think there are places to possibly look at that and add in. If I look at the survey results from our survey, increasing transparency through the supply chain, holding companies accountable for transparency, and the whole story of drug costs. So I think there's often a question of we don't know who's bearing the cost or where the benefits or the rebates are accruing. And so creating that way to tell that story. There's a graphic that I've seen a couple times, and it's sort of, here's what the supply chain looks like, and it's really complicated. And so how do we create more breakdowns, and how do we have insight into all the different parts of that diagram? I think there's more and more that can be added to the list to chip away. But I just wanted to flag that there is quite a bit. I mean, Oregon does have two strong programs that are providing a lot of this foundational work, and there are still improvements to transparency to layer on.
Great, thank you. Mary Beth?
Yeah, I think, Sarah, you mentioned something about transparency and like explanations as to why prices were increasing, like due to market factors or something like that. I think that would be really interesting. But also with Oregon's transparency program, we've seen less price increases and more just high starting prices for new drugs. And so I wonder what transparency options there are for that. Either, explanations for why a market price is set, or maybe there's information in the rebates that we'll find out more, if Senate Bill 404 passes or something like that, that will provide a better picture for that. But that is something that I'm interested in.
Yeah, and that's I think the prescription drug price transparency program does look at specific price increases, but only for, price increases that are above a certain threshold. So it's not necessarily a comprehensive look at all prescription drugs in the system.
And Sarah, I think Mary Beth's point could be added to the aggressive approaches, which is, does the state have the ability to do a deep dive on pricing of new pharmaceuticals new technology, some of those pieces. So I think we're at time, and I wanted to recap just briefly. Sarah, if you would kind of summarize some of those slides for us, maybe put it in the appendix for the next meeting on state and federal capabilities so that we know our parameters. We'd like to think a little bit about what are the barriers to group purchasing, and is bulk purchasing an opportunity for us as a state to improve cost of members. I really like the concept of where does consumer protection step in, and is that a lever that we can use to start thinking about everything from patents to starting prices of new drugs? And then obviously the transparency initiatives, and where can we be supportive of some of that work that's already been done? Anything else that I missed in that conversation?
I saw Hardesh come off mute. Want to make sure we didn't miss something from him earlier. And then Gil had a comment in the chat about PBMs.
Great.
No, I just had two things. Say thanks, Sarah. One was I'd be interested in knowing what the governor introduced in Connecticut as a legislation. So if there's some details around that and work that was done to introduce that legislation, would be great to know. And it's some aggressive moves. I think that we focused on price, but there may be some transparencies around drug utilization, right? Appropriate utilization, overutilization, brand and generic utilization. Are there incentives? Are there? And I hope there's no providers here, but is there incentives to providers that are incenting them to over prescribe? And that would be an aggressive move based on right utilization of drugs, appropriate utilization of drugs, and so in that arena, not on the price side, but on the utilization side.
Gil, did you have a comment?
No, nothing to add to my comment in the chat, but just I think it's just another plea for more transparency, in the process, because it's hard to wrestle with something that is totally out of your control, from a
Yeah, I think that's very fair for those of us that actually negotiate with PBMs. Spend a lot of time working on it, have consultants that support us in that process. It's as opaque and confusing to us as it is to you. Ivy, I saw you come off mute at one point. Do you have a comment?
That was an error. I apologize.
Certainly not. Lawrence, you have your hand up. You're on mute.
One quick addition to your excellent list on the aggressive side. Even if we can't import US drugs internationally, if we established a transparency of this is how much Oregon would save if we could, it might add to the pressure there, just to add to your list.
I really appreciate some a realistic approach as opposed to the wish list. We'll certainly add that. Thank you all for your discussion today. I think, as we've talked about, this is an important step, and one that we can get our hands around. I think there's unanimity across really everyone from consumers to providers to plans to various not-for-profit organizations that really support these initiatives, and it could be a place we could really make a difference. Sarah, back to you.
Okay, I think there's a long list of ideas. I really appreciate everyone weighing in. I think when Peter, Felisa, and I do our sort of meeting debrief and planning for the next meeting, we'll talk a little bit more about how to bring this back. I mean, do we just put all of this forward as a laundry list and say the committee recommends, or do we want to have more discussions? I think we'll come back with some more concrete next steps, but I think this was a really good broad discussion. And I think I would probably plug if people have additional thoughts, especially if you go back and you look at any of the previous meeting materials about some of the strategies and you want to send those over email to add to the list, please do so.
Great. And I'm clearly willing to throw out very crazy ideas. So if you have ideas that you are nervous about, don't want to, and I know you all negotiate with pharmaceutical companies, give me a jingle, send me a text. I'm ready to put it out there. Everyone has my cell phone number. So after this, we have a break before we're supposed to talk about our public hearing and get into that. I think that we are we're still running a little bit behind. So I'm wondering if we can shorten this break to just a 5-minute again, and then Sarah, go ahead.
Can I actually counter propose? I think there's a really natural breaking point between talking about the public report and the public hearing. So why don't we go ahead and do some of the public report, because that's a little bit more informational, and then we can break and then get into the public hearing discussion.
Okay, as always, Sarah is smarter than all of us. Let's do that and jump into the public report. So I think we're gonna pull back up the slides. And we're gonna be at slide 40, I believe. Okay, I think probably slide 41. Here we go. This is a slide I hope that folks remember and that we are continuing to sort of think about as we are on our annual cycle. So we have a public report coming out this spring, and this is it's a big one. And so I think will be the first time the payer and provider organization level cost code relatives to the targets will be published. And, you know, I think that there's obviously a lot of interest. I feel like you can see just from our discussion earlier today about the questions and the other comments. And, you know, I know many payers and providers on this call, like I could see you tense a little bit. It's going to be okay. I feel like, and how do we have a public hearing where we get that tension out? How do we have a sort of setting where we see all of those things and then reassure people this is really about our shared goals, about how we're making and sustaining healthcare in our state and making it affordable for everyday consumers. We all have an agreement on that while maintaining our quality and access to our care. Those are our shared goals. So how do we have a public hearing that really outlines that is based in data, and knowing that, you know, all of us in this, we've survived a pandemic together, and our system, although, you know, I think in some trouble, it still survived a global pandemic, the first in my lifetime, and I think many of our lifetimes. And so, and how do we build and keep that resiliency moving forward? And so I think let's take a look at this, the summary, but I think we should keep, I think, a little bit of that frame in mind in that public hearing, both the holding the tension that is going to happen, and knowing that we're going to move forward for a more resilient system. So, Sarah?
Great. So I want to share a little bit about what we're planning for the public report and the public hearing, and starting with the public report. But I want to ground us first, not just in the annual cycle and everything Felicia just said about what we're doing here together, but also where we came from and our implementation committee, predecessor committee recommendations. Next slide, please. So in the implementation committee recommendations, there was a whole section on transparency. And there were 3 primary mechanisms that are recommended for the cost growth target program. We are implementing all 3 of those. The first one is development and publication of reports, publication of data files that go along with those reports, and then public hearings. Next slide. So we've been working on those reports. We had a conversation earlier today about one report for 18, 19, and 20. That recommendation, this is leading us up to fulfilling these recommendations from the implementation committee. The implementation committee recommended that we should have an annual healthcare cost trend report. It should include performance relative to the cost growth target, information about healthcare system performance, and it should include a number of specific analyses. And this is a little bit of a brainstormed list from the initial committee. So Are we achieving the cost growth target, both in a given year and over time? What does our per capita growth rate look like? What does our per capita growth rate look like compared to other states, compared to other economic indicators? So a lot of the questions and comparisons that we were just having in that discussion are things that we will be including in our annual report, sort of year over year, and that we're building towards fulfilling this recommendation. Next slide. We are planning on a report this spring. This is going to be that big report. I think the data that we were sharing earlier, that might be a smaller report, more of a data brief, but this one will be the big report. We're thinking about releasing this, hoping to release this in late April, early May. This will be the measurement period of 2020 to 2021. So adding one more year to the data we were just looking at. It's again coming from the cost growth target data submission files. So the data that is being submitted to us for this program, it includes claims, non-claims, net cost of private health insurance, other public programs. We will report at the state and market level, and as said, the payer and provider organization level. Next slide. So in the state and market level data, I think that
Hey,
is all going to look.
Sarah, I'm sorry to interrupt. So if you go back and you think about having that 20 to 21, will that be available in that in those trend slides as we start to think about the committee meeting and the public hearing?
No. So I think my plan is that we are going to have two reports that come out pretty close together. So there'll be the state and market level trend. That's all the data we looked at earlier in this meeting. And then we'll have this larger report probably a few weeks later. We're delayed. Ideally, it would not happen this way. Ideally, we space these out more annually, but I think they'll be coming pretty back to back. So everything we looked at earlier, plus some additional things, will be part of that state and market level trend in both reports for both 18, 19, 20, and then 2021. So we'll see all of those same service category breakdowns at the state and market level. We'll see the dollars in billions in total. We'll see the per person per year growth. We'll see the growth rates. We'll also share some of the longer term trends over time, like we've shared in some of those claims-based reports. So yes, all of that is intended. And then in this later spring report, we will add the payer and provider level data. And I wanted to just give a little bit of a preview for that, because again, I think this is where people are anxious. We've had a lot of conversations with our technical advisory group. We've had a lot of individual meetings with payers and providers reviewing this data. And there's a lot of concern about how am I going to be publicly reported. So just wanted to share with you all what we're planning. Next slide. So for that payer and provider organization level trend, we are intending to publish the year-over-year percent cost trend, so percent relative to the target, not the dollar amounts at the payer and provider level. And there's some reasons for that I can talk about, but basically we're not necessarily comparing apples to apples. The dollar amount on a per member basis at a pediatric practice is going to be really different than a large hospital or health system. And we don't want to necessarily present that like it's a fair comparison. So we're planning on reporting the trend, not the dollars. We will be reporting this with confidence intervals. You might remember, if you've been tracking this work for a while, Oregon was the first state to adopt this approach. So only, in the future, when we say, did someone meet or not meet the cost growth target, we will be taking those confidence intervals into account to make sure that we have statistical certainty that the cost growth target has been exceeded. So whether the target was met or not, and then a lot of narrative providing context. And we're getting some really great feedback from people about what the right narrative and what the right context and pieces of context are to include to supplement this data. On this side, you can see a pretty high level de-identified fake data graph. This is the level of visualization that we're intending to include at the payer and provider level. So each of those organizations will be on a payer chart, a provider chart by market, and you'll see performance. So sort of across like groups. We're thinking about one graph to put all the pediatric practices together, one graph to put all the Medicaid CCOs together. So there'll be some groupings. It's not just going to be a really long laundry list. But this is what will be shared publicly. And you'll be able to see pretty clearly target met or not met. And just a quick refresher on the confidence intervals and interpreting this graph. Organization A on this graph, the blue dot is their year-over-year cost growth. And then the confidence intervals, both the top and the bottom of those confidence intervals, are above the target. So we would say organization A has exceeded the cost growth target definitively. Organization B Their blue dot, their year-over-year cost growth has also exceeded the target, but their confidence intervals overlap the target. So we would not say whether or not that organization B has met or not met. They would be indeterminate. And then let's go down to the bottom. Organization J, blue dot, year-over-year cost growth is below the target. Top and bottom of confidence intervals are below the target. Organization J has definitely met the cost growth target. So that's the interpretation. There will be a lot of organizations in that gray area where we cannot say definitively one way or the other, and then we'll have met and not met. And just for the record, no accountability applies for this period. This is just reporting for transparency and for additional discussion and understanding. So met or not met, that's as far as it goes. And I think, again, speaking to that tension, we've had some discussion with folks about, well, yes, and what will the media say about this report? And will, the media run with it? And what are the potential implications and the optics of being reported? And just coming back to transparency is just a really critical mechanism of this program. We have to know what's happening in the system to be able to come up with strategies and ways to address the cost growth. So I hope this provides just a little bit of context and maybe not reassurance about what will be in this report. For the payers and providers, we have shared much more detailed organization-specific data output. There's a lot of granularity in that data that will not be published. We've told all the payers and providers that individually. So there's a lot more nuance in breakdown that will not be publicly reported, including the actual PMPM or PM per member per year dollar amounts. Okay, and one more slide, and then I will stop talking.
Sarah, one quick question. I'm sorry, sometimes I can figure out where the hand raises. As you think about that new spend, which was the population health category, that's going to show up as spend in healthcare. Does that show up in these trend reports?
Yes.
Even though it's this piece that's really trying to drive population health and sustainability.
Yep. We're measuring total medical expenses at the payer and provider level, which will include all of that spending. So I think there's a question about, what percentage of that and how much of the growth was being driven by that. And that's fair and possibly something to dig into in the future, but it will be included in the top line.
Yeah, I think in the future, as we hone this work, thinking about where are those capital investments going, or where are those system investments going that are really going to drive our ability to hit that sustainable target over time, and how do we think about those differently than just pure cost on an annual basis?
That's great. I think that might be something our team thinks about a little bit more, about reporting trend for the claims and non-claims categories with some different variations. So we'll think about that. But officially, what is compared to the target is inclusive of all of it. Okay. One thing I wanted to say is how many payers and providers are we talking about? So we do have thresholds for inclusion. So there's a threshold for inclusion in terms of payers that have at least 1,000 covered lives in Oregon have to submit data. Not all of them then meet the additional threshold for public reporting. There have to be a certain number of members by market before we report. So this is how many payers and provider organizations in each market we anticipate including in the report. So there are 29 payers statewide. We'll report commercial trend for 8 of them, Medicaid trend for 16 of them. That makes sense, 16 CCOs, 10 for Medicare Advantage. On the provider organization side, we have 51 provider organizations that meet the threshold. But again, that's broken down. There'll be 21 provider organizations that we report commercial trend for, 46 where we report Medicaid trend, and 12 where we report Medicare trend. So definitely a lot of variation. And as you think back to the slides and the data that we shared earlier for 19 and 20, 18, 19, and 20, there's a lot of variation across market. So we will be reporting payer and provider by market to show that rather than overall rolled up, because it just masks so much nuance of what's happening. So let me stop there. Questions or comments about what's in the public report?
So, go ahead, Gil.
Yeah, I was just curious if there's a consumer perspective at all, as to how costs may be trending for out-of-pocket deductions, co-pays, that sort of thing, to sort of provide that perspective, as well as what's going on with payers and providers.
Yeah, I had the same question, on the 3.4% cost trend, how does that convert to a affordability for just the, general community in form of, lower premiums or co-pays?
So I think this is a really good time to talk about some of the inclusions that should be included in the report. And so some feedback around that. I think the consumer perspective is a great add. I think that highlighting the system investments that Peter laid out is a great add. Are there other ways that people think the report could be enhanced? So, for example, I think, how do we highlight some successes, right? People are going to fall all over this little bar graph. Are there ways that we think, how do we highlight successes? How do we make this data usable? I definitely think a report for report's sake and transparency for transparency's sake does help do things, but are there thoughts on, when you look at this, if you're a payer or provider, Shannon, I think, you have a unique role here in helping consumers make decisions. Are there things or ways that this can be usable that you would add?
Let's see.
Yes, go ahead, Shannon.
It's hard, so yeah, out-of-pocket amounts, copays and stuff would be great things to add in, but it's kind of hard to tie that into kind of the 10,000 foot level that we're looking at, because consumers are down on the ground paying for it every day. So I've been actually really thinking about that. How can we tie in the consumer perspective and have this information and also this work be meaningful to consumers? I think right now it's kind of abstract and hard for a consumer to see, how does this impact what I spend at the doctor's office, so I don't have an answer right now, but I'm thinking about it.
Do we have anything that show information that show from a consumer, right, standpoint, I pay either copay when I go to the doctor's office, or I pay insurance company premiums, healthcare premiums, and those, is there a corresponding trend that, do you have that information that we can show in addition to the reduction in cost trend? Here's the premium trends and copay trends, because obviously lower cost should result in lower premiums and lower cost, out-of-pocket cost. So it might be that we might need to couple that, because that's what, the lower cost trend should result in lower cost for the community.
Yeah, that's a good. Mary Beth?
There's a question in what I'm thinking about, but it's not fully formed. So I'll just kind of lay out a short thought process. And that's that our payers and providers often participate in multiple markets. And some of those markets are more governed by the federal government than they are by state regulators. So just trying to parse out, I guess, how we can play a role in limiting cost growth versus, what has to happen on the federal level with all this breakdown.
Yeah, that's I think a very good addition. I think some of the business folks on the call, if you want to jump in, Ivy or Julie or other folks, about how maybe this data we can use to sort of think about self-payers and how we get more self-payers to start reporting, or how we're communicating to some of the self-payers or other, because I agree with Shannon on that, 50,000 foot view, but as purchasers, is there something in this that would be helpful?
Well, Julie, so I mean, we always look at trend data. We should look at nationally, right? Because we have a broad population, but we also do look at regionally, where we have regional plans that we compare to. So from just a pure trend comparison point, it's a nice data point to have. I think you're going to get a reaction about, maybe that's why you have the confidence levels of apples to apples, right? Are we adjusting for many factors that one could be increasing versus another. And you also said earlier, you know, a large increase can translate to small dollars, right? So what's their starting point? And since we're not providing total cost, it's hard to assess, you know, are they increasing because they have a whole bunch of new members, or, you know, and the cost is going up, but only slightly. I don't know, there's a lot of variables in there that you're going to get a reaction, right? And you're expecting that, and you're trying to understand what's in there. I also know there's you know, from our side, there's a trend to put more fees in that employers would pay directly, and then the cost of claims are kind of subdued on a self-insured basis. So, you know, there could be some of that happening here too when you're trying to compare one to the other. So there's just, you know, a ton of questions that it would actually cause me to ask myself if I was comparing it, but it's a nice, easy reference point to be able to point to if you're looking at a regional comparison point for your plans to see how they're performing.
I think that's really helpful. And I think maybe a one pager at the end of the report that talks about that a little bit for some of the folks who are doing that comparison, and sort of that private commercial market might be helpful. Ivy? Did I freeze? Ivy, did you freeze? Oh man, Ivy, I think you came off mute and froze. So if you can hear us, jump back in when you're ready. Other things? Oh, go ahead, Sarah.
Can I ask a question for the committee? I think this is something Julie's comment just sparked for me. And this is a conversation we've been having with our technical group about how to present the data in the report. And I think the point about enrollment changing and, you know, attributed patients at the provider organization level, that's really important because these organizations are not all the same size, and that does matter. And I think I neglected to sort of share that we do want to somehow convey that. So I don't know if that just is a data table with enrollment for these years and you can see the change, or we've talked about how to incorporate that in the graph somehow fun. And, you know, TAG members gave us some mixed feedback on whether or not that would be useful, but I think given Julie's comments, it seems like that would be helpful. And I asked the committee for maybe a gut check on that.
Yeah, and Ivy's back. So
hi, yeah, sorry. Hi, everybody. I'm having internet issues. I was sneaky chatting with Sarah directly because I think the plans.
Oh, Ivy, you might turn off your camera. You're cutting in and out.
No, I'm frozen again. No, I'm frozen. Here we go. Yeah, I'm gonna have to lower my bandwidth here. Yeah, okay. There, can you hear me now?
Yes.
All right. So yeah, my thought here is that I think the plans and the provider groups are going to want quality data, because I think, you know, there's all kinds of studies around quality, and if there's high quality or there's higher cost, and there can be yes and no around that depending on the study that you look at. But overall, I think they're going to want to see this data coupled with quality data as well. And it sounds like we're going to be able to do that in the future. So I hope so.
Go ahead, Sarah.
Sorry, I'm brainstorming in ways that my team is probably going to kick me for, but we could do something like pull the CMS Medicare Advantage star rating down and drop that into the report beside the cost. I mean, I think there's some questions about, you know, is that the right comparison, and are they all reporting, and do the measurement periods line up? And we can think about that, but we have the CCO quality metrics we could pull. I think it gets a little more complicated for the commercial market writ large and for the provider organizations, how we do that. But I think there might be some easy things that we could pull. I'm just a little hesitant to do it for some markets and not others, or some payers and not providers, if we don't have something consistent that we've all sort of agreed on. But there is existing data out there that we could leverage maybe in the short term.
Yeah, I don't think any idea right now is a sort of off the table. So I think there are things from the payer or providers on this call that would make you feel like this report is going to be useful. I know I want to continue to recognize the like tightness everybody feels right now because it's coming out. So one of the things I think is really important, Sarah, is that those payers and providers see the report in advance of it being public. And I usually am not that person. I'm kind of like, as we just saw, put it out and smack them in the face. Ha. I think that there's a strain in the system right now that sort of activity is probably not the best. And I know that the data has been verified with them, but can you lay out that?
Yeah, so all payers and providers have seen their own data that are going into this report. We've had validation conversations with them. We've offered meetings to discuss. I think a lot of folks on the call have been in those meetings. So everyone should know what their data point is. I think where the tension is how will it be presented? So we shared some of the de-identified mock-ups of the data at our February technical advisory group meeting. We had some really great feedback, and we're planning on coming back at the March meeting, which is next week, and sharing a little bit more of what that will look like. I'm a little hesitant to actually sort of share a full draft of the report, I think, with so many entities before it's published, but I certainly hear the concern, and I think we are planning on sharing more of that in March, and possibly even at the April technical advisory group meeting, to say, here's how the data will be presented, here's what the graphs will look like. Right now, everything's mocked up with fake data, but just giving a better sense of, you will be grouped with these 5 organizations on the chart might help cut into that a little bit. So I don't know if that's far enough, but I am pretty sensitive to do we just blast it out and sort of give the state an opportunity to comment? I don't really know how to handle that.
So I do think I just want to put a pin in. So we have a March technical advisory committee meeting where there's going to be more feedback on this. So people who are listening to this publicly, and other people in your networks, please push that out so that people know that that's another time to comment, and that there's going to be these additional meetings, and that's another time to comment, so that people don't feel surprised. And I'm hoping that we can count on the network of, we're a small community, so I'm hoping that we can count on our community network, and I'll ask the payers and providers and other folks in that network to try to push that information out as widely as you can. So again, there are no surprises. Lawrence?
I'm wondering if, as an intermediate position here, we could share with each payer and provider their chart that showed the chart that's going to be published, showing their name, but not showing the other names. So one could at least see
Where you are relative. Yeah.
where you are relative, but you couldn't see, well, there's Joe here or Sally here, right?
Yep.
That might be helpful, because it would at least give people a sense of, a little bit more data would be helpful, I think. And that would be useful, I think.
Okay, noted.
The other thing I would just note is, I'm used to a lot of volatility in our business. I've never seen volatility like these last 3 years. So, the trend over time will become more and more useful, I think, for everyone.
And I think that opening, there's always the opening of the report. So laying out that level of, I think there's a combination here of volatility and recognition in the system. I think, I can speak for just our members who work on the direct patient care side, and they are feeling they have reached a point of giving everything. I would say that they feel like they have. And so, and then I know people who work in this health systems and in this in this world also feel that way. There's and I think we're seeing that in turnover and all kinds of changes. And so recognizing that at the front end, how this is meant, and then laying out maybe the changes that we've decided as a committee, like that we've, the PIPs and sort of moving the accountability dates and other things like that right at the front end of the report, I think is a really important recognition of the last several years that people have survived.
And I thank you for that. I think absolutely we can add that. And we're getting similar comments in our individual conversations with payers and providers, as well as at the technical advisory group. And I feel like it's fair to say that at least 2 folks have shared with me comments along the lines of, you can put all of that context in the report. People aren't necessarily going to read the narrative. They're going to take the chart and run with that top line visualization. And yes, understandable. So I think we will do as much as we can to provide that context and do all that due diligence and add that. And also, people might not read it.
Yeah, no, I totally want to recognize people are going to flip right to that chart, right to where their name is. I assuming there'll be a lot of find in when people get the report. Find my name, find my competitors' names, find this, find that. It's human nature. I'll probably do that too. But I do, I think when we think about communications out, and I especially think to media, how the media takes and runs with this, I think that opening narrative, I think, is going to be really critical. So are there other components, knowing that there's going to be feedback on this, and I want to get us to our public discussion about our public hearing. Okay, again, not your last time. So as always, please give the staff feedback, and then we have this upcoming tag meeting. If you're a payer provider, you'll have additional meetings in between now and this May. And I just also want to recognize this committee's work on this and sort of staying the course here. And know that each and every one of us are going to have to steel ourselves for May, because I think what is going to happen is there's going to be a flare up in our organizations that we work. There'll be a public flare up, which will cause a legislative flare up. So please get ready for those, and know that our job is to sort of, as Lawrence and Peter have said, like, we've got to look at the year over year, but we've got to look at the long term, and keep that greater vision in mind, that beautiful flower that we've created. So Sarah, do you want to move us on to the public hearing?
Yeah, do we want to take another 5-minute break or keep going?
Where are people at? 5 minutes or keep rolling? 5 minutes. 5-minute break. Recording. Thanks. I feel like that 30-second warning is always a bad idea, because it just tells people they have 45 seconds. All right, I'm going to bring us back together here to talk about our public hearing. So this is our first public hearing. And so we're going to want to move on to slide 51 is my guess. And I'd like to just turn it over to Sarah to set the frame for the public hearing. And then I'm going to open it up for a discussion about what do we want this public hearing to look like? What are people's ideas? Have we seen public hearings that we feel like work, knowing that we're holding this sort of tension and North Star? So Sarah?
Okay, thanks. Next slide, please. Real quick, I want to summarize the recommendations from the implementation committee about the public hearing. So the implementation committee said the purpose of public hearings is to foster a common understanding across stakeholders and state leaders of the biggest challenges and opportunities related to healthcare costs. The public hearings will be grounded in performance relative to the cost growth target and will support open dialogue around opportunities for improving care and reducing costs. Next slide. The public hearing, the committee also made some recommendations around the logistics of the public hearing. So the Oregon Health Policy Board should be responsible for hosting and convening the public hearing, and there's sort of a range of what that could look like. Public hearing should be annual, should include some elements used by Massachusetts, which was the only state that had been doing a public hearing at the time that we were having this conversation. A formal but collaborative approach. The Massachusetts public hearing, for any of you who have not seen the clips, is very formal. They swear everyone in under oath. They have them testify. There's sort of attorney general grilling. It's very legal and formal. So the implementation committee sense was that we should have some of those elements, but it should be more collaborative. And that we should ensure participation of an appropriate cross-section of stakeholders. So that should include hearing from payers and providers, employers, purchasers, consumer advocates, and executive and legislative branch representation, as well as making space for public comment. So a lot of things that we potentially could be holding in that. Next slide. We did hold a public hearing in April of 2022. There's a screenshot with Shannon presenting. Thanks, Shannon. This public hearing in April was really focused on the impact of healthcare costs to people in Oregon. So we focused on hearing from some national perspectives on what was happening. We looked at the impact and a lot of data around how high healthcare costs impact people, delaying access to care, medical bankruptcy. And we had some really great panelists, payers and providers sharing their stories, healthcare consumers sharing their perspectives, telling their stories. This was a really different public hearing than what we're about to talk about. So I want to recognize that we did this and we had this hearing. It was a virtual hearing. It was well attended. We had great legislative and leadership representation, very strong panels, recordings available if people want to go back and look at any of that. And also, I think the public hearing we are about to talk about will likely be different because now we are going to be talking about payer and provider level performance. We want to keep it grounded in some of these impacts, but it might also be much more about health system performance. Okay, and one more slide from me. We have been talking about May, so I want to propose one thing to you all and then give it to Felisa for discussion. We could repurpose our May 17th advisory committee meeting. We are holding 3 hours on everyone's calendar for all of you to have an advisory committee meeting. I think certainly we have lots to talk about. There'll be a report that we can dig into. We could continue our pharmacy conversation. We could also hold that time as the public hearing. We could also look for a different time in May and find some time that's available and publicize that and hold that in addition to the May committee meeting. So I want to maybe pitch that as the first question of, should we repurpose the advisory committee meeting in May to be the public hearing, or should we find separate time?
Can we take down the slides just so we can engage a little bit? So I actually am going to recommend a little bit of a different process. Sorry, Sarah, before we get to the date.
Take it away.
I actually think I want us to talk about, I want us to set the purpose of the public hearing and the outcomes that we want to achieve. And then I think that's an important component to then get us to, okay, is May the right time to achieve those outcomes? Or should we work on picking another date? And I know dates are very hard and the staff are like, can't we just pick May? I get that, but I just I just want to talk about the purpose and the outcomes first, and then let's circle back to, can we meet those by May? Do we want to pick another date? So if people have thoughts on what do we want to get out of this public hearing? What's important to you when you think about sort of a bigger, more public hearing, bringing people together, hearing from providers and payers?
Just share what, so we're sharing data at the session. I'm not sure. I'm not going to share the results of the where everybody sits on the trend, or we're sharing that part of it.
That will already be out.
That'll be out. So we post that.
Okay. Yeah, it'll be posted.
And can I add that we've had some specific requests from folks that the report is out for at least a week, if not 2, before we hold the public hearing, to give people a chance to digest. I think in Massachusetts, they come out very close together, like the report comes out and then the public hearing's the next day in some years. We've had a specific request to give more time for digestion of the report before the public hearing happens, and that's what we're planning on, which is given our timing of early May and then maybe May 17th, maybe not, but definitely there'd be some spacing.
Okay, great. So plan right now, we release the report, all the data, we have a 2-week period. Woo! And then we have a public hearing. That's my 2-week period. That's my 2-week period. Dance. So when we think about that, what do we want to get out of this public hearing? And I would say this is as much for the public as it is. And so you think about the audience for this public hearing, it's, the general public, which I think is a big piece. It's the payer provider community who is implementing this. It is legislative leadership. And it's also us, right? The public hearing is really a time, I think, for people to give us feedback, for us to hear about where we're going, like what are the next steps? What do we need to know? So that's who the that's I think who the audience is. Hardesh.
No, I'm just saying who is doing the presentation, and is it just a presentation on cost trend?
Well, I think this is what we have to decide right now. So I assume that we'll want a presentation of the overall data, and that will be done by the health authority, knowing that they'll have done probably several of these presentations before the data will be out. They'll put some stuff out about it, but we'll do sort of a level setting. And then we can choose some formats. So I'm going to throw some ideas out here, and it would be good to get people's sense. So we could do a format where we have 3 panels that we recruit and prep people for, right? That on how they've digested the data. So we could have a panel of insurers, we could have a panel of consumers, we could have a panel of providers, sort of giving feedback and hearing from them specifically that we've specifically reached out to. That's one way to do it, right? We could have group breakdowns in the public hearing. I think Massachusetts has a very, very formal process. And I would recommend us not having that formal process because we're not ready to sort of have that level of accountability with people. So if we think about this, like we could have those panels, we could have group discussion questions, right? We could have a public hearing and break people into groups and have a set of questions that were, maybe each of us take a room to facilitate. So we could have breakouts of us facilitating to ask a group of people questions to get feedback. That's another kind of public hearing type. Or we could have the formal process that Massachusetts has on the table. I don't want to take that off the table because I don't love it, but we could say, okay, what we're going to do is we're going to have a very formal process. We're going to call a set of providers who are above the target range and who are above and below the target range, and we're gonna ask them questions as a board. That's another option. Peter?
As I think about the audience, I think it's really important to kick this off with the recognition that the public has no idea about this block of work. And so whatever we do, we need to tell them what the law is. We need to tell them what our obligation is, how we're moving into it, how the pandemic fits right in the middle of this, so that when you get to some of those report questions, there's some context for folks. I think that's really critical. I do not think we are at a place to have the formal Massachusetts process. I think we are at a place to outline how we're going to build sustainability for our state over time, give the public and maybe the legislatures some understanding of the body of work, the dedication of stakeholders, and the process we're going through, and put some context to the report in that light. And then I'm sure we'll end up having to dig into that report to a certain degree. I don't know. Those are my thoughts.
Great. So I'm hearing, I think people are staring at me blankly. So I'm going to go, I'm going to ask a more specific question. Is there anybody who feels like we're ready to do the formal Massachusetts type hearing? And is there anybody who would sort of advocate for that path?
No, I don't think we're there ready to do that yet. I think we just need to be more prepared to be, to have a formal thing. I think this is the first, maybe almost the first one, and maybe it's information sharing and seeking, feedback.
Great. So
What
I
are
think, oh, go ahead, Julie.
So what, I'm sorry, maybe I'm just not that familiar with what a formal meeting is. Are there pros and cons
you of having a more formal meeting, by doing that you avoid X, Y, and Z, or having a more open meeting, you can subject yourself to X, Y, and Z? I mean, I'm not really sure I understand the construct, but is there benefits to a formal meeting that you could just share with us?
I mean, I think in my opinion, a more formal meeting heightens a sense of accountability. That's one benefit to a more formal meeting. I think, one of the cons is a more formal meeting. It's people who don't feel like they're ready for that accountability, or people who are not sort of familiar with a more formal process have a hard time participating. It really does impact an equity lens when you have a more formal process and hearing. I think, Sarah, go ahead.
Two clarifications. One is that, regardless of the format, these will both be public meetings operating under Oregon's public meeting law. So that will be the same no matter what. They will be available for people to listen in, recorded, all of that good stuff. Two, I think when you think about the Massachusetts format, that when we say formal, they're swearing people in, they have panels where it's a Q&A, like they're basically testifying about their cost growth target performance. It's less conversational. It's justify yourself, which I think is the heightened accountability Felicia's talking about. And also, Massachusetts has a much smaller number of payers and provider organizations that are subject to the target. And so when they think about, we're going to invite the 3 payers that have exceeded the cost growth target, it's 3 payers out of 10 versus in our case, that slide we were looking at a few minutes ago, we have 30 payers and 51 provider organizations that we might be selecting from. So I just want to put that into context, like when they're thinking about who they want to hear from and how they want to hear from, they have a much smaller pool of entities that they're talking about than we will have in our program.
Is there some point in time where we do believe that there needs to be a more formal setting?
I think we can decide that. So we're going to do these meetings annually. And so, I think, that when the PIPs, the performance improvement plans happen, that's a moment in time, I think, where people, if there is a performance improvement plan, I think that's a different, we might ask ourselves different questions at that point. Or if people have been on a performance improvement plan and have decided to blow that off for some reason, that's a different time.
Right.
I think there's also, when you think about, this is the first time we'll have data and it's just looking at 2020 to 21, which we know is a little bit of a weird year in the data impacted by COVID. When you think about Massachusetts, they've had 10 years of this. And so they're saying, we can see your performance over that whole time. And how has what are your patterns over that time? So I think as we add more and more years, as we roll forward, the payers and provider organizations that we might want to hear from might change as we see more longer term trends.
Yeah, thank you. That's super helpful. And I totally agree. A non-formal setting would be best at this point in time. So I appreciate you guys going to next level for me.
No, that was a really great question. Okay. So I'm sort of getting us to a sense of consensus on, we're going to go non-formal. I think the next set of questions then is sort of that setup. So is it completely, do we do panels, or do we do sort of more, like, what do you want to get out of this? What I've heard is we want information sharing. We want context setting. If you had to ask yourself one question right now, like, this report's about to come out, you guys have all seen the sort of layout and all of those things. If you wanted to ask yourself one question right now about, what would it be? Like, if you wanted to ask a question of the provider community, to the insurance community, what would that question be? To consumers.
How are you containing costs, right?
How are you containing costs? Okay. That's a great. Other folks?
I would ask if the first round of data or the conversations with OHA have changed anything for future plans.
Great. Peter?
I think there's a context that we need to ask providers about workforce issues, and how do we bring these two issues together, cost containment and long-term sustainability of our workforce.
Great. Stefan?
Yeah, I think it might be interesting from a consumer perspective to know about out-of-pocket costs, especially in the private health insurance.
Okay. Other folks?
I have one more. How do we pay
Yeah.
for this?
Sorry, Stefan, can you say again?
How do we pay for it?
Okay, great.
Lisa, I think there's a question, and this may not be the right format for it, but how does redetermination impact this going forward? I think about uncompensated care at the provider level. I think about reductions in members being covered, et cetera, et cetera. And this may be the completely wrong forum for it, but I think that some of that will bear out in future numbers, and maybe we take it down the road.
Great. Ivy?
For the consumer, what would we have projected? I don't know that we have that on there. So what's the marker?
Great. Other folks, any other questions that we would throw out there? Okay, I'm gonna do a sort of a quick summary. Oh, go ahead,
Hey,
Peter.
Lisa, I'm sorry to interject, but I think the discussion that we just had around pharmacy is important, and where does pharmacy play into some of this? And it's probably worth highlighting that question.
Great. Any other? Okay, based on this, what I think this is the what we want to get out of this hearing. So what I've heard is what we want to get out of this hearing is a consumer perspective on what is the out-of-pocket? What did we project for consumers? How does this work impact consumers? I think we want to know from providers, how are you containing costs? How are you given this data? How are you thinking about or adjusting your future plans? We want to have a really firm context setting around the public and legislative understanding around where we're at with big challenges, right? So when I think of those big challenges, that's workforce issues and our long-term sustainability. That's the pandemic issues. That's also the pharmacy costs, right? And how we're grappling and struggling with pharmacy costs. And then that's also Medicaid and redeterminations and uncompensated care and the shifting of the market, right? And sort of hearing and laying that foundation. So if those are the things that we want to get out of this hearing, who are the right set of people that we want to hear from on those? Who do you want to answer your question? Sarah?
Sorry, can I ask a clarifying question on that list of what we want to get out of this hearing? I didn't hear anything in the summary about anything from the payer perspective. Is that also important, or was that a deliberate exclusion?
Good point. I don't think it was a deliberate exclusion. I think we're all like, no. So what do
I think my question, which was just about like how are conversations affecting future plans, and by that I mean like future plans to meet the cost growth target. I think that applies to both payers and providers.
Great. So I think given that sort of list, which is like, that's what we want to get out of this hearing. I think, actually, let's go back before we move on. Do we think that we can get those things out. And I think we might need to shorten that list. The public hearing is 2 hours. The recommendation is 2 hours, May 17th. 3 hours, Sarah? Okay, the recommendation is 3 hours, May 17th. I don't think we're going to answer all of those questions, but I do think that's enough time to sort of give us a place to hear from the different perspectives on those questions. Does May 17th seem like enough time from now until then, thinking what's going to happen next is the staff is going to sort of put out an agenda to this group to say, here's our thoughts and ideas for the public hearing. And then we're going to want to recruit and get the right people in the room by May 17th, which is 1 month away, 30 days to answer those questions. So are we good with that May 17th date? That's my next question. We all have it marked on our calendars. Hopefully the vast majority of us can make that. Or do people have strong thoughts about not having it be May 17th?
I think it's really good to do it timely to when the report comes out. I think we might need to shorten that list a little bit and maybe refine it to more. I'm sorry, I don't remember who was talking about kind of setting the table as to what this report's about and here's what it is. And then, give people a year to digest that and understand the context, et cetera. And then we come back the next year with a more, okay, now you've seen it. Here's the second report. Now let's bring in those folks to answer those questions. I'm just concerned there's not a whole lot of time between now and then. It seems like a long time, but it'll disappear really fast. So
I agree. I also just want to put a pin in that we're required to have one public hearing a year. We can have another one. So we could divide this into sort of 2 bites at an apple. We don't have to never have another public hearing till the following year again, to Julie's point. So I feel like Julie's proposal on the table, like that May 17th and Sarah's proposal is right. It's very timely. So can we?
Can I make a proposal, like I guess a revised proposal then? Because I think if we were keeping the May 17th meeting as the advisory committee meeting, we would be very focused on the report and the data and discussing the data. So from a context setting perspective, absolutely. I think that would be a really overlapping agenda. I think for me, when I think about the public hearing, it's not just time for the committee to talk. It's time to hear from or to ask questions, which is great and important. And also it's a time to hear from the rest of the community, the consumer perspective, the purchaser perspective, the payers and providers. So whether or not that's in 2 meetings, I kind of like that idea, but I would really want those to be pretty close together. If we don't think we can do them all rather than, 6 months apart. But I do think that if we're keeping the May 17th meeting as the committee meeting, we would absolutely be focusing on the report, the data, and the context.
So I think there's a couple of things. I feel like from here, we're going to go to okay, who do we need to hear from? And we have a lot of folks who are sort of that payer provider community as well as general consumers. And we know that the payer provider community is very large compared to other states. And we also know the context setting is really critical. If you divide the meeting in half, frankly, where you have half the meeting be that context setting and the other half of the meeting be hearing from folks, to answer these questions, I'm not sure we actually have enough time to do that. And so I think my question is do we set another meeting very close to that May 17th timeline for that public hearing where we sort of break this down into 2 components? We do one sort of set of context setting, questions about the context setting, that we have sort of that component, and then we do another hearing, I don't know, maybe May 18th or something, which is back to back, to sort of lay out these panels and questions. And I think to Shannon's point, I do think that the reality is, and to some other folks' point, I think Peter's point, the general public, I think we say the public oftentimes, and that's not very real. And I want to recognize that, this is not I think we can push this out and put this out as much as we possibly can. But if you're an everyday Oregonian who's just going about your business and going to work on the regular and doing your day-to-day gig and you're not really grounded in healthcare, you most likely aren't showing up to this hearing unless somebody finds you, recruits you, talks to you about getting there. Otherwise, you're just living your life, unlike all of us nerds on this call. So I want to recognize that we'll have to do that. We'll have to do that component to get that consumer perspective. And I think the same thing is very true with the business community, right? You're just like trying to crank out your small business or your medium size or your large business. And you hire very smart people like Julie to do this, but you're not going to show up to this either. So I feel like that really, to those components, I think we might break it down a little bit where we could have a half time where we do that recruitment and then we have another sort of bigger payer provider day. Peter?
I'd almost, based on your comments, I'd almost try to see if we couldn't be efficient and use the time that's already blocked to communicate this initial piece. I do agree that as we get more and more data over the course of time, there's going to have to be a lot more ability to bring various providers, various payers into the room to do that work. But I'm not sure that if our goal is to communicate the work we've done to the legislature and the work that we've done to the public, that we can't do that in this initial meeting.
So can I make a suggestion here? I feel like one of the things that I think is really important for us is to sort of get to like the components of who we want to hear from. And I think we did, I think we did sort of get that a little bit in this context. I'm going to make a suggestion that we do the May 17th as a public hearing. And that what we're going to accomplish in that is our context setting. The laying out of the big issues that we are sort of facing. And the discussion about the impacts on, and so a little bit of information sharing. And then what I'm going to say is that my suggestion is, I think we come back at a later date in the fall, have another public hearing after people have had time to digest the data. They've thought a little bit more about it to answer the questions. How are you containing costs? And what are the changes in the future? What are your sort of future looking plans that you're setting? Because you've seen it now, it's out, you're on the list. And having that sort of be the September timeline. I also think what would be good is we have to recognize that the legislature actually is in session during that May hearing. And they won't be during a fall hearing. And so maybe we could get more participation on that future looking items from the policymakers, the policy setters in that fall timeline. How does that sound to people? I'm getting a thumbs up from Shannon. Head nods from Grace. Thumbs up from Stefan. Thumbs up from Julie. Great. Nick, Lawrence, Ivy, anybody want to revolt on this idea? Okay, is that helpful enough for the staff to sort of lay out, seeing a variety of thumbs ups and things? I feel like we have consensus on this like breakdown. Is that helpful, Sarah? And does that give you enough to move forward?
Yeah, so let me restate what I think is happening for May. We're going to repurpose the May advisory committee meeting into public hearing part 1. We will share the report. We will do context setting. I thought I heard you start to say possibly hearing from consumers. I want to make sure that that's not necessarily just all presentations. So maybe we need to have a little more conversation, and I can do this, Felisa and Peter, we can take it offline about if there is interactivity in that, but I think we have enough to start. I'm a little nervous about May to September as a gap, because then it feels like we're gonna forget the context and have to do all the context over again in September, which is okay, we can do that. It gives us more time to schedule and get something on calendars. The pro of separating them like that is in the May meeting, we could then have a much more tangible discussion about who we want to hear from to be invited for September or part 2 panels or whatever that looks like. So I like that. I think doing that staggered will help. I do worry about sort of loss of momentum, and this data is lagged and it'll be even more lagged by the time we get to September.
Yeah.
Maybe that's okay. I think that's a trade-off. And if the committee wants to create that space between them, that's great. I don't know if it's May, September or something else, but I think doing it in 2 parts rather than trying to do like 2 full days, which is how Massachusetts does it. I'd be really nervous about pulling off 2 full days in May, but I think we can definitely do part 1 in May on May 17th. And this gives me enough to go on, even if we still have some outstanding questions about the rest of it.
Yeah, and I think Ivy has a question in the chat is, will public hearing have call-in or Zoom? So I think we'll have to talk to the staff and like the facilities about, do we do that in person? Is it a hybrid? What does that look like? But that's a really good point for access. And I'm going to be super honest here. I am an Oregonian, and so I like my summer. I try to never schedule anything in the most beautiful time of our lives. So, and I know others don't, others also enjoy that activity. So, I think having something when people are around to participate and really engage, I think is also important. So I'm not gonna pretend I didn't space them apart for that reason, but I will suck it up and think about June and July as well. It's probably still gonna be raining in June.
That's fair. I think this is enough to go ahead and start communication around the May 17th meeting. And my plan is that May 17th will still be a virtual meeting. I don't know about later, June, July, September may not be, but I think May, we should plan on that being a virtual meeting.
Okay, great.
Okay, thank you.
Peter?
Public comment. Do we have any public comment? If so, you have 2 minutes for your comments, and please state your name and organization before you kick off with your comments. We did
No
not
one
have-
has indicated in the chat or otherwise that they would like to submit public comment.
And we didn't have anything submitted in advance in writing.
Nothing came in writing this month.
We'll give it another 15 seconds. And hearing none, I think we'll close that.
Okay. Peter, Felisa, sorry, I forget who's wrapping us up.
I don't.
I think this is going to be a
I
really
will wrap
direct.
us up. And thank you for the highlights on the agenda. I appreciate that. Thank you very, very much for today's meeting. I think we're starting to get into the meat of the work that we're doing, both on thinking about costs, on thinking about trends, on trying to paint this program so that it has some sustainability in its own right and it can be impactful over a period of time. And it's less about slapping hands and it's much more about how do we actually contain costs for our community members. It's a really, really critical issue. It's something we think at the health plan about an awful lot. How do you make this work affordable? It's really vital what each of you do every day. Really, really appreciate that. If you have comments or thoughts about this latest discussion about the public hearing, please get them to Sarah and she can communicate that to us in advance. and we'll go from there. Sarah, anything else that we missed?
No, this was a really full meeting. Thank you so much, everybody, for your engagement and for giving us all of the feedback. It's really helpful in shaping our work and figuring out what we're doing next. So I feel like I have some good follow-up items and marching orders for May. Thank you.
So we are adjourned. Thank you. Have a great day.